The case is it's a 5 years female child from Tirunelveli whose informant is mother. Chief complaint is absence of a right thumb since birth, and there is a difficulty in using the right hand for daily activities like eating and playing and routine daily activities. So there is no history of breathlessness, no history of any bleeding manifestations, no history of any bowel and bladder disturbances, no history of any hard of hearing, no history of any previous surgeries, and no similar history of illness in the families. These histories are taken to rule out other syndromic associations. So antenatal history, this is a non-consanguineous marriage, second-born child. So full-term normal vaginal delivery. Child cried immediately after birth, and there is no NICU admission. So general examination, the child is alert, active, and further examination, there is no craniofacial deformities, no capillary spots noted in the body. And cardiovascular and respiratory system is normal. Abdomen is soft, no scars. Chest wall and spine normal. The rectal examination, the patent anal opening, external genitalia is normal, and all the toes were normal. So examination of the hand, inspection in forearm is supinated, wrist neutral, and all fingers were extended. So the inspection, there is a complete absence of the right thumb, and there is absence of thenar eminence, absence of thenar crease, and the absence of proximal and distal wrist crease on the radial border. And when comparing the right hand with the left hand, the right hand is smaller in size, and all the fingers were shorter in comparing to the remaining fingers of the left hand. So this is a short video on examination and for the inspection. The child can able to hold the large objects using the 4 fingers, and the child can able to hold the smaller objects like pen using the index finger and mid finger. While holding this small objects like a pen, the index finger is slightly abducted and pronated. There is a scissoring movement between the index finger and mid finger, so that the child can able to hold the pen. Examination, a range of movements at the shoulder joint, abduction, flexion, extension is full. Elbow joint, flexion and extension is full. Forearm supination is present, pronation is present. Both in elbow is flexed and extended. Wrist flexion and extension is present. Fingers, all fingers at all proximal interphalangeal joints, distal interphalangeal joints, and metacarpophalangeal joints, both flexion and extension were full. Measurements, arm length is same in both upper limb. It is 19 centimeter. The forearm length is on left side, it is 15 centimeter. In the right side, it is 14 centimeter. There is a 1 centimeter shortening present in the right forearm. Ulnar artery and radial artery pulsation is felt, and sensation over the both the palm and dorsum is intact. So I have a X-ray of the hand of both the hands in AAP and oblique view. There is a total absence of the thumb ray in the right hand in this X-ray. And further examination of the X-ray, there is a absence, the presence of only the distal carpal rows, and the proximal carpal rows were absent in this X-rays. So
Dr. Nishar, can you go back to the X-ray of the normal side?
Yes, sir. So in the normal side, both the proximal and distal carpal rows were present, sir. In the affected side, only the distal carpal rows, 3 carpal bones are there, and proximal carpal row, only 1 carpal bone is visible, sir.
Okay, thank you.
Can you zoom the lower end of radius?
Yes, sir.
No, AP.
Yes, sir.
Okay. Proceed.
So my diagnosis is congenital aplasia of the right thumb. It's a type 5 of modified blood classification.
So Can we question him or let him finish the presentation?
Sandeep,
Yes,
please
sir.
tell Dr.
Sir,
Purushottam what is the
it's
protocol.
like a general this one, sir. So you can break at any point of time and then you can do the questioning, sir.
So I would like to further discuss about the X-ray.
Yes, sir.
So what congenital hypoplasia of the thumb you said, how do you account for the proximal row absence? And also I feel the radius is slightly short.
Sir, yes, sir. I have only the X-ray of the hand along with the wrist, sir. From this X-ray, I can able to say only the absence of thumb rays and proximal carpal row is absent, and there is a mild shortening of the radius compared to the opposite side, sir. To comment about the, we can comment whether there is a radial longitudinal deficiency also, but only we have to take a full X-ray of the forearm, sir, along with the elbow joint.
And radial club hand, have you seen the distal radius being present and proximal being absent?
Sir, no, sir. In
So how
type
do you
2, sir, yes, sir. Because in type 2 radial longitudinal deficiency, the distal epiphysis will be absent. Proximal, it is hypoplastic, sir.
proximal will be hypoplastic?
Yes, sir. In type 2.
So, Dr. Nishar, is this a RLD or not?
Sir, it comes under radial longitudinal deficiency also, sir.
Good.
If at all, it comes under
Yeah,
type
that's
1
what
radial, it comes under
Good.
type 1 radial longitudinal deficiency
Correct.
with the type 5 thumb aplasia of blood calcification, sir.
Very good. Correct.
That's what we
In
want.
fact,
Yeah.
when you mentioned the proximal row, you
Yes, sir.
should have mentioned the slightly shorter radius also at the same time. That's
Okay,
a concomitant positive finding. In all cases where the forearm is essentially looking okay and the thumb is absent, you must always look for the slightly shorter radius, which is
Yes,
very
sir.
nicely seen here.
Yes,
And
sir.
as far as the proximal carpal row is concerned,
Only
it's
scaphoid.
too early. The child is too small. I
Yes, sir.
agree with you that the left is showing more than the right, but something might emerge in the right later. Ideally, you need a MRI to find out how many and which bones are present and whether they are normal or there are abnormal coalitions of the bone and so on.
Yes, sir.
And
Anything else you
especially-
want to present, or we can ask you questions? You have finished,
Presentation
I
is
think,
over.
your presentation. You have come to the diagnosis, right?
Diagnosis and investigation treatment is pending.
Yeah, what investigations will you do?
Sir, first of all, I will do blood investigations, chest X-ray, ECG. These are all for the purpose of anesthesia purpose for surgery, and also to rule out some congenital anomalies and also this associated syndromes. And I don't have any X-ray forearm with the elbow, sir. So I will take X-ray forearm with elbow and X-ray spine, echocardiogram, ultrasound abdomen and pelvis. Sir.
Very good.
So,
Anything in the blood you will look at?
Yes, sir.
Anything
Sir,
in the blood investigation?
Yes, sir. In blood investigation, I will look for thrombocytopenia or pancytopenia, sir. Because
And? Thrombocytopenia and?
it's a pancytopenia.
What is it called when it is there with RLD?
Sir, it is Fanconi's anemia or
Correct.
thrombocytopenia and absent radius syndrome, sir. It
Correct.
manifests earlier than the Fanconi's anemia.
Very good. Very good.
And chest X-ray, I will look for any cardiac shadows enlarged because it is associated with the Bacterial syndromes. So there might be any ECG changes if at all present. X-ray forearm to rule out radial longitudinal deficiency. In Bacterial syndrome, there will be vertebral anomalies. So I will take X-ray spine to look for the vertebral anomalies. And for the echo, I will take to rule out cardiac anomalies. It will be present in most of the syndromes like Bacterial, Fanconi's, Holter, uncharged syndrome also. So echo will be taken to look for a atrial septal defect or ventricular septal defect. And ultrasound abdomen and pelvis I will take to rule out renal anomalies.
Very good. Very good.
Doctor,
Yes, sir.
you said in general examination,
Yes,
you
sir.
did a PR examination, am I correct?
Yes, sir.
Is it routine?
Sir, it is not routine, sir, but in this case, it will be helpful for
Yeah, but
others. Other system examination is important for this case, sir. So,
no, just by external examination and history, the patient is passing defecation normally without
sir.
any strain or anything. Will you
Yes,
go
sir.
and do a PR?
So it's not exactly PR. We have to examine the external anal opening whether it is
But
present
you
or
have
not.
mentioned as PR. That's why I'm asking.
No, sir.
Will
That
you
is
do a PR? Will you do a PR for this child?
no, sir. It is a examination of the external anal opening whether it is patent or not. Because in Bacterial syndrome there is anal atresia, and
What is the age of the child?
it is 5 years.
5 years.
So they might have operated for this case. So I have examined the abdomen for presence of any scars.
History you can take and any scar you can see. History itself will tell you whether there is any problem with it. There's no
Okay, sir.
need to mention PR. That's what the
Okay,
point
sir.
is. Okay?
Yes.
Proceed. So when compared to right and left,
Yes, sir.
is there any difference in the wrist movement?
No, sir. Wrist flexion extension were comparatively normal in both the hands, sir.
Both sides?
Yes, sir.
Okay.
So treatment, sir.
Treatment.
Yes. Sir, the treatment for this child is polycysation. And before proceeding for polycysation, I will counsel the parents regarding the procedures. There is a pre-surgical counseling has to be done for this
What
procedure.
is counseling spelling? Sorry to pick you on this.
SCLLIN.
Huh?
COUNSCLLIN.
Please check it.
Okay,
Okay,
sir.
go ahead.
Sir, I will do pre-surgical counseling, sir, regarding the procedure. Like it should be done under the general anesthesia, and the index finger has to be mobilized in place of the thumb. And after the procedure, patient has to be admitted in the hospital for a few days. And after the procedure, there will be a splint or POP. Then post-operative physiotherapy is mandatory for this patient, and the child should learn the newly positioned index finger to function as the thumb. This all has to be explained to the patient, and post-operative complications also has to be explained to the patients.
Dr. Nishar, can I ask a question?
Yes, sir.
I can make out that you have got some plan in mind and you have written that also. But would you consult with the patient regarding this plan or any other plan? Will you discuss any other plan with the patient, with the parents?
Not with the parents. So there is a total absence of, in this case, it is a total type 5, so there is no thumb at all. So
Yes.
the only option is the child is using index and mid finger to hold the objects. So the index finger is already, it's acting as like a thumb, sir. So the only option for this patient is polycysation.
Supposing the parents say, sorry, you
Okay.
want to take the index finger away because it is acting like a thumb now. But
Yes, sir.
I want my child to have 5 fingers.
Yes, sir.
Will you think about some other plan then?
Sir, we can do a second toe transfer, sir. But in this child, there is an absence of extrinsic flexors, both flexors and the extensors, and the intrinsic muscles are also absent. If at all we do toe transfer, it will act like a static post only, sir.
Why? There will be flexion and extension of the fingers. You can take one FTS to motor flexor tendon, one index extensor indices to motor extensor.
Yes, sir. But the child already learned to use the index finger and the mid finger, sir. So there is a chance that the child may neglect using this.
You don't want to give that option at all.
So when compared to second toe transfer, this polycysation results are better. So my first preference will be the polycysation, because child may neglect using the second toe. when we do second ultrasound.
Okay, but you need to remember that this option also must be kept in mind.
Yes, sir.
Supposing a parent does not want it.
Yes,
Okay,
sir. Yes.
right. Please go ahead.
Treatment.
He has finished now. We have to ask him questions.
Yes.
So this marking you have done is of what marking of polycization? What technique?
Sir, Bagram course.
So then you are missing one line on the side over here. On the palm that comes down, there is one more line.
Go back,
Sorry.
go back. Yeah.
You know the dorsal, you have those two triangular flaps. When
Yes,
those
sir.
flaps split open,
Yes, sir.
there is a triangle which is taken from the bottom of the new thenar eminence that is forming. That fits into that. So there is another line there. You have drawn everything correctly except that line.
Okay, sir.
Just go back and check in the book.
Okay, sir.
In polycization, can you tell me the equivalence? What becomes FPL? What becomes EPL? What becomes APL?
Yes, sir. Sir, FP, there is body equivalence and muscular tenderness equivalence. So in muscular tenderness equivalence, FDS and FDP tendon of the index finger become the flexors of the newly formed thumb. Sir.
Okay.
And we will reconstruct the extensors also, sir, and the introsseous also.
Yeah.
Dorsal introsseous and palmar introsseous we will release from the index finger and it will mobilize. So this dorsal introsseous will be repaired to the radial lateral band, which act as the abductor pollicis brevis.
Thenar eminence. Acts as the thenar eminence.
Yes, sir. Thenar eminence, and it will also act as a abductor pollicis brevis. Sir.
That is part of thenar eminence, Dr. Nishar.
Okay, sir.
Yeah.
Then palmar introsseous will act as a adduction, sir. Adductor
Correct.
pollicis.
What about the two extensors? What will
Sir, yes, sir. Extensors, there are two extensors, EDC and extensor digitorum communis and extensor indicis pollicis. This extensor proprius, this extensor indicis proprius, we will release its attachment from the metacarpophalangeal joints so that it does not act on the metacarpophalangeal joint. It acts only at the distal interphalangeal joint.
Very
so
good.
that it acts as a extensor pollicis longus, and extensor digitorum communis, which is left as such, will act as a abductor pollicis longus, which is more radial.
Very good. Very good. Very good. Anything else? Any difference in the bones between index and thumb?
Yes, sir. Distal interphalangeal joint of the index finger will act as the interphalangeal joint of the thumb, sir.
Yeah.
Proximal interphalangeal joint will act as the metacarpophalangeal joint of the thumb.
Yeah.
And the metacarpophalangeal joint of the index finger will act as the carpo-metacarpal joints of the newly formed thumbs.
And what happens to the metacarpal then?
So metacarpal, we will do osteotomy at both at proximal and distal level. So we will remove it.
Okay.
Second
Very good.
metacarpal.
Any particular step which Professor Bugram described of the metacarpal head?
Episioid.
No. Episioid disease is all right. That is to prevent growth. But there is one very specific step which he introduced for the first time in polycization.
Hyperextension.
What you said?
Hyperextension, sir.
To prevent hyperextension.
Yes, sir. Because there is usually there will be slight hyperextension of metacarpophalangeal joints. So that is not needed in CMC joint of the thumb. So
Correct.
the dorsal capsule is sutured with 4-0-proline at extended position so that further hyperextension will not occur.
Not the capsule, Dr.
Sure.
Nishar. The bone is rotated.
Yes, sir.
The head of metacarpal is rotated and then sutured in that position to prevent the hyperextension. That is the critical step.
Okay, sir.
All right.
So how do you?
Sorry. Go on, Dr. Pushut.
Somebody was asking.
No, I was asking, but you go on.
No, How do you, in what position you place the new thumb and how does it stay there? You put any-
Sir, yes, sir. So this after osteotomy, this index finger is abducted 40 to 45 degrees, and it is pronated 120 to 150 degrees, facing the mid finger, sir.
and
That
how
is
do you-
40 to 40 degrees of abduction and 120 to 150 degrees of pronation. It has to be rotated, and it is fixed using KY, sir.
use KYS?
Yes, sir.
KYS going from where to where?
Sir, from metacarpophalangeal joint, metacarpal of the head, proximal interphalangeal joint, and proximal phalanx of the new thumb to the carpal bones, sir.
You will fix all of them, not required. You just need to fix the new CMC joint, if at all. Some of us don't
Yeah.
use K-wire, but even if you use K-wire,
Okay,
you
sir.
don't go through all three joints. As far as possible, don't violate the joints with K-wire. What you need to do is the CMC joint fixation.
Yes, sir. That is
So all of them are
metacarpal.
not required. Just do
Okay,
the
sir.
CMC, and for the last 20 years, I haven't used a K-wire, but that's a different matter. Some use, some don't.
Okay, sir.
We use a roll-in suture to anchor
That's
there.
right. We also use a suture and fix it in the gap in
no
the
care.
CMC that is created by the removal of the second metacarpal. And then we rely on the tendons that we repair
Okay, sir.
to maintain the position.
But
But that's
here,
okay. That's K-wire. We will not
we
question you
use
about
KY.
K-wire.
Okay, sir.
GK, anything?
No, sir, I'm okay with this.
Okay, one more last question, I think, Dr. Nishar.
Yes, sir.
What will you do about the slightly shorter radius? Because that leads to positive ulnar variance.
Yes,
And
sir.
in the long run, will put pressure on the carpus on the ulnar side. So can you do something about it? Plus, there is a slight radial deviation in these children.
Sir, if at all, we have to take a X-ray forearm and a elbow also to determine the length of the radius, sir. If it is less than 2 centimeter, 2 mm shortening, it is type 1. So
So this
mostly,
is type 1, Mohammed. I'm telling you, this is type 1.
yes, sir.
Forget the X-ray.
Okay,
This
sir.
is type 1 with some radial deviation seen in the wrist.
Yes, sir.
So are you going to treat it or you will leave it?
So type 1 mostly doesn't warrant any treatment. So I will straight away treat only this.
What about growth? With growth, the ulna keeps pushing the carpus.
Then do ulnar osteotomy.
Okay.
Reduce the ulna.
Yes, sir.
Okay, what is done is we do a tendon transfer of ECRL to ECU to
Okay.
correct the deviation at a very young age,
Okay, sir.
around 2 years of age. Now this child is already grown to 5.
Okay, sir.
And then we liaise with pediatric orthopedic colleagues and we take X-rays serially.
Okay, sir.
And if we feel that the ulna is pushing too much, either the radius is lengthened or the ulna is shortened.
Okay. Yes.
So you can't ignore that radius forever, because by the time the child becomes an adolescent,
Okay, sir.
might start creating trouble with the slightly longer ulna.
Okay, sir.
I think very good job. What are my co-examiners thinking?
Yeah, it's a good presentation and yeah, good presentation and good way of answering the questions. He's got all the facts on his fingertips.
Yes, yes.
That's good.
Thank you, sir.
Thank you.
Thank you. Thank you, Dr. Nishar. You presented extremely well. Thank you, sir. We are exactly on time. Thank you very much for keeping the time also. So now we'll go to the next presentation. Dr. Karthik is going to talk about a case of syndactyly. Dr. Karthik, can you share your
Yes.
screen?
Dr. Nishar, you shut your screen.
Yes, sir. Switched
Karthik
off.
has started sharing, sir.
No, I'm still seeing Dr. Nishar's screen.
It's So in the meanwhile, can I just ask a question, sir?
Yeah.
In the post-operative management, no, do you do any special physiotherapy for the patient, sir?
Actually, I was going to question him on that. So, physiotherapy as such is not required. Play therapy is required. And some taping of the middle and ring finger is required to prevent, especially in a 5-year-old where they are used to chopstick. They just move the chopstick to the next 2 fingers. So you need to put a paper tape on the next 2 fingers to prevent the kid from using them as a new chopstick. So
Okay.
that the child starts using the thumb. Otherwise, they don't. But when we do early, like we do, around 18 months or so, hardly any training is required. They just start using it.
And so suppose that child is presenting to us after 8 years of age.
Yeah, then a long counseling session is required because some of them don't use it. So,
Yeah.
in fact, in medical legal ethics, now they say child above 7 up to 12, a verbal assent is required, if not a written consent.
Okay.
So, child above 7, we need to have detailed discussions with the child. Show him pictures of a polycization, show what is possible, ask for his or her consent whether they want it. Sometimes they say no, and then the parents can't override a child of 8 years. Legally now, you can't override a child of 8 years if child is not giving assent. In
Okay.
our country, this step is not often followed, but for example, when we file ethics committee papers, and if the subjects are children, we have to mention this, that verbal assent will be taken after 7 up to 12 and written consent after 12.
Okay, sir. Is there some age after which you would not do the case, sir?
So oldest I have done is 6 or 7 years.
Yeah.
That child took 3 years to start using it.
Okay.
And bilateral. And she was very, very difficult about it. And the heartwarming part of the story is when she was 12 years old, she one day came to my clinic on her own and said, I have a gift for you. And I said, really, what gift do you have? She said, this is a poem I have written using my new thumb and holding the pen the way you were telling me all these years. Finally, she became an engineer, got married. I don't know about her kids.
That's so heartwarming.